So chapter 20 is the neoplasm and cancer. And these are general terms that we need to understand. What's differentiation? Differentiation means cells, each cell is supposed to do a function, right? In order to do a function, it needs to be differentiated first, in order to do a particular function. So if the cell is differentiated, here is what I mean. I'm going to tell you what's the most important, but this is just for us to understand before we go forward, okay? So what's differentiation and what's the importance of that in neoplasm and cancers? Here's the importance. If everything in your body is normal, everything is fine, okay? So the cells are replicating, the cells are replacing under normal circumstances, you will have completely normal cells. Meaning if this is a normal liver cell, it will be differentiated to do the function as a normal liver cell, right? What happens if you have a tumor? You have a faster pace, right? So the cells will not have the time to differentiate. So if you see the cell that's not differentiated, it means there is something wrong. It's going through tumor. This is exactly like this. If I ask you to do some bread, for example, okay? If I give you enough time, you give me perfect bread, right? If I rush you faster, so give me 20 per day, you do perfectly. Do 30, okay, good. If I ask you to do 300, you give me anything, right? It's not even, you didn't even have the time to bake it, so you give me something that's raw, something that's bad, right? Which is not differentiated. So differentiation needs time. If you have a tumor, it will not be differentiated. This is one. Mitosis, I think you're familiar with that, mitosis, how the cells divide. If there is anything that you don't know, just let me know, okay? Just raise your hand and I will explain it. But mitosis in general is part of the cell cycle, and this mitosis has to be controlled. Mitosis is one cell makes two cells makes four cells, and so on, okay? Irrespective of the details. But this has to be controlled. So, you know, like for example, you lose some of your skin, right? You know that we replace our skin on a daily basis, right? You lose some of your tongue cells on a daily basis. This is something normal, right? So you lose it, you replace it. I lost 200, I replaced it with 200, right? This is controlled. If you lose the control, the mitosis will go 1, 2, 4, 8, 200, that's it, enough. No, 500, 1,000, 5,000, so it will go uncontrolled. So mitosis has to be controlled. When can it be uncontrolled? If mutation happen. Mutation happen means you lost your control over the mitosis, basically. Apoptosis is one of the protective mechanisms, and this is important to know, okay? It's important to know what apoptosis is. So apoptosis is programmed cell death, and this is controlled by genetics. So programmed cell death, so the cell are going to die. Is that something good or bad? It is actually something good. The cell are going to die, but it's good. Why? Because the lifespan is over. You don't have to have it more than that. Example, the red blood cells should die after 120 days. How is it going to die? It's programmed, right? And this is apoptosis. Did you understand that? So what happened if you lost your apoptosis? You have cells that are going more than it should. It's not going to die by itself. You keep it and you do more and more and more. And this is tumor. So apoptosis is something that's very important to know. Now what's neoplasm or tumor? Neoplasm is the same as tumor. Neo is a Greek for new in English. So neoplasm means new formation. You're forming something new. So basically the cells are going to grow and multiply and replicate beyond the normal. So the cells are going to increase dramatically beyond the normal. Okay? And because of that, the cells are going to be deprived of nutrition. You have nutrients that are enough for the normal cells that you have, right? So your body, you know that you have 10,000 cells in your skin. If the 10,000 become 50,000, there is no enough nutrition for those, right? So some of them are going to die. The cells are going to look atypical or immature, and this is very important to remember. This is the most important part in this. Atypical and immature. What does that mean? Atypical means we know, histologists know how the typical cells looks like. I know this is a perfect liver cell. This is the perfect skin cell. It will not look like this. It will look different. So this is called atypical. And immature because you're rushing the cells, right? Now nomenclature, this is all extremely important. You have to know this. You have to memorize it and understand what is this. How to call the name of the tumors, okay? Any benign tumor will usually end. This is a general rule, and there are some exceptions that I'm going to talk about. If you see oma, like this, adenoma, benign tumors end with oma, okay? Malignant tumor, which is the same as cancer, they have something different. It can be either carcinoma, if the cells that you're talking about are epithelial cells. If it is connective tissue, you call it sarcoma. So it's usually something end with carcinoma or sarcoma. Are we following so far? This is very important. Oma, only. I know that sarcoma end with oma, but you have the whole term. So if you see sarcoma, know that this is connective tissue. If you see carcinoma, know that this is a cancer of the epithelial cells. Now how to know the cells from each other? Which cells are connective tissue cells? How to know them? Here's the rule, and this is A and P. I don't know if you still remember or not, but here's the rule. Think about it this way, because it's not detailed here, but you can understand it and you can easily get it, okay? Here is the rule. Are the cells that are we talking about are epithelial, so it's part of the skin or mucous membrane? No. Is it muscles? If no, is it nerve tissue? Is it the nervous system? No, it's connective tissue. So a bone, connective tissue. Is it one of those? Is it skin, mucous membrane? Is it muscle? Is it nervous system? If you say no to the three, anything else is connective tissue. Did you get the rule? So so I don't have to mention one by one. If I say bone, tumors, bone cancers, it will be osteosarcoma. How did you get the name from? Because I know the bone is connective tissue, right? Why it's not? It's connective tissue because it's not one of the three. Did we understand this rule? So always ask yourself, is it one of those? If not, then it is connective tissue. You name it. How about fat tissue? Is that one of the three? Is it skin? Is it nervous tissue, nervous system? Is it muscles? No. So it is what? Connective tissue. How about the blood? Connective tissue. Bone, connective tissue. Cartilage, connective tissue, right? Anything that's not one of those, by exclusion, it's connective tissue. So we are going to use the suffix what? Sarcoma. Sarcoma. If you understand the rules, you're going to apply it, and you're going to get the questions right. But understand the rules. Always ask yourself, step by step, what kind of tissue do I have? Is it one of the three? Yes or no? Yes, you have a name. No, then you're going to, it's connective tissue, and you're going to use sarcoma. Okay? So let me ask you this. Bone means osteo. The bone is type of which type of tissue? Bone is? It's connective tissue, right? Bone is connective tissue. So the bone means osteo. What do you want to call it? Osteo what? Osteosarcoma. Okay, cartilage means chondro. What do you want to call it? Chondrosarcoma. Isn't it connective tissue? How about lipids? Lipo. Lipo what? Liposarcoma. Right? Did we get this idea? Okay. The only exception to that is some tumors have a unique name. Like a scientist or something, he didn't follow the rules. So he said, no, I'm gonna call it on my own name. Like Hodgkin disease, for example. Okay? This is a scientist. He called it Hodgkin disease on his name. Wilms tumor, same thing. Wilms tumor is a tumor of the kidney. Kidney, so why don't you call it something OMA, for example? Because he wanted to call it this name. Leukemia, this is cancer of the blood cells, the white blood cells. Okay, carcinoma or cancer of the white blood cells. And they call it leukemia. So if it is not one of those, you follow the rules. Ask yourself, is it connective tissue or not? Connective tissue, you got the name. Put sarcoma beside the prefix. This is important to know. Did you get it? So here it is giving you some examples that you need to know. Tissue is lipe. Fibrous tissue. It's fibrous tissue. Is it a muscle? Fibrous tissue, is it a muscle? It's not muscle. Is it skin or mucous membrane? No. Is it nervous system? No. So what is it? Connective tissue. So what do you call it? Sarcoma. Fibrosarcoma. Did we get the idea? Liposarcoma. If it is cancer, if it is benign, you put OMA. Is that clear? Benign, put OMA. So prefix and then put OMA. If it is cancer, connective tissue, put sarcoma. Not connective tissue, put carcinoma. That's it. And you can name everything, whether it is benign or tumor. If it is glandular tissue, you call it adeno, means gland. Adenocarcinoma, for example. If it's coming from the epithelial cells, you call it carcinoma. If it is something from the connective tissue, you call it sarcoma. This is the whole thing is important here to know. Benign tumors. And we mentioned it already. It is differentiated. How to know if this tumor is benign or malignant. This is very important to know also. Is it benign or malignant? What's the first thing that you need to notice? The cells are differentiated, typical. If you're looking at the cells itself, it has to be differentiated, typical, and looks normal. Remember this. Okay? The cells, in order to say, like, I have a tumor here. Can you tell me what is that tumor benign or cancer? Okay, give me a sample of your cells and I will tell you. Right? Look at the cells. Does it look differentiated? Yes. Does it look typical? Yes. Does it look normal, even though it's a tumor? But it looks normal? Yes. This is benign. This is on a histological level of the of the tumor. Okay? On the tissue level, it's usually encapsulated, and there is usually a tissue damage, and this tissue damage is what can cause death. So here is an example. We all know that benign tumors do not lead to death, right? We know that. Cancers, it can lead to death. But the exception to that is, how about brain tumors? Are benign tumors, does it lead to cancer? It actually does. This is an exception. Why? Because you know that your brain is within the skull, and this is a confined space, right? So the benign tumor, not the tumor itself, but it's going to grow and compress on the brain until you die. So this is one exception, that the benign tumors, because of the tissue damage, they can cause tissue damage. They do not follow any other rules for malignant tumors that we will talk about, but they can cause tissue damage. So if I ask you, malignant tumor in the brain, is it fatal? Can it lead to death? Of course, yes. How about benign tumors? In the brain, yes. This is the only exception. Why? It's a very confined space, tissue compression, death. Okay? So the characteristics of the benign tumor, on a cellular level or the tissue level. Cellular level, it's not all here, but I'm telling you what you have to remember. It has to be differentiated. Typical looks normal. Is that clear? Differentiated, typical looks normal. How about from the tissue level? It should be encapsulated. Encapsulated means like this. If this is a breast and this is a breast here, and this is cancer, it will be like this. Okay? If it is benign tumor, you will see it like this. Encapsulated. Okay? There is a capsule. So if you want to remove it, they take it out with the capsule. But this cancer, it doesn't have a capsule, and it's going to spread in. So it is encapsulated, and we talked about the tissue damage. How about the malignant? It will be the other way, the opposite of that. So it will be undifferentiated, atypical, it looks abnormal. right? Which is the opposite of what we mentioned here. And the other thing is it going to spread or not? This was encapsulated, right? Benign. Malignant tumors are not encapsulated. Because they are not encapsulated, there is no capsule around it to limit it. It's going to spread, and this spread is called the local spread first. So it goes like from this to the rest of the breast, more, and then it's going to start to go to the muscles, for example, which is behind the breast, and then it go to the lymph and blood, from which is going to go to another spot that's completely different. So it can go all the way to the bone, for example. So what do we call this? Moving from one spot to more spots, you call it spread or invasion. The moment that it reaches the blood or the lymph, it's going to leave this whole area and go to a completely different area, and you call this metastasis. So there are two types of spread. Malignant tumors spread. It's not capsulated, right? Spread to what? To the adjacent cells or a distant organ. Adjacent cells, this is just invasive and spreading, just invading and spreading in the surrounding area. If you reach the blood, and this is your key, blood and lymph, when you reach the blood or lymph, now the situation is different. A piece of the cancer left the original spot and reached somehow to the blood or lymph, and now it's going to circulate until it go and attach to itself to a completely different organ, like bone, like lung, and so on. Did you understand the two types of spreading? Local or distant spreading. If it is local, you call it spreading or invasion. It's invasive. If it is distant, meaning you reach the blood and the lymph, or both of them combined, now we're talking about metastasis. None of that apply to the benign tumors. None of that. The benign tumors will be like that. I mentioned the brain is an exception, but it will stay like that. Can it grow? Yes. But within the capsule, and it's not going anywhere. Can bother you? Maybe, but that's it. No spread, no metastasis. No spread, invasion, or metastasis. Did we get this rule? So here is a benign tumor, a malignant tumor. The cells looks relatively normal. It's typical, it's differentiated, slowly growing, and it's not going to spread, invade, or metastasize. Now look at this. You don't see a capsule, right? Look how the cells do not look typical. Each cell, cells looks different than others. There is no capsule. It looks irregular, and it's going to invade the surroundings. So here is summarizing everything. But I told you already what you need to know. Differentiation, is it differentiated, typical, normal, looks normal. It's more cells, but normal. Did you get this idea? Benign tumor looks just like the regular cells. It's just more. The cancer doesn't look like normal cells. Okay? So benign cells are typical, differentiated, looks normal. And then on a tissue level, it's encapsulated, no spread or invasion. All right? Cancer is exactly the opposite. It's atypical. It is undifferentiated or poorly differentiated. Right? Does it look typical? Does it look normal? Does not. And it's going to invade the surrounding and then metastasize. Okay? The malignant cells will lack the control of mitosis, and I talked about this in the beginning. The mitosis is controlled. So you can duplicate your number, you can increase your number to a certain extent exactly to cover what you need. You lost something and you replace it. In this case, you lose the control. The organization and the differentiation, so it's poorly differentiated. No contact inhibition, the membrane will look abnormal, and so on. Okay, but again, most important is what I told you already, right? Typical, normal, differentiated. Encapsulated, no invasion. This is benign. Malignant, atypical, undifferentiated or poorly differentiated, doesn't look normal, invade and metastasize. What I just mentioned is the most important of all. Okay? Meaning, if you forgot something, do not forget what I just mentioned. Okay? On the other hand, the cancer will also can lead to necrosis and inflammation. So if I have this section of a malignant tumor and benign tumor, I have a cut section. I take a look at it. If I look at it, if it's benign, I will just see normal cells that's increasing and encapsulated and all what we mentioned before. If this is a cancer, beside what we mentioned, which is no capsule, it's atypical, it's poorly differentiated and all of that. But because of this competition on the blood supply, parts are going to die and parts are going to inflame, and death is called necrosis. So you also see necrosis and some inflammation. With that happening, the cells are competing, right? You used to have 5,000 cells in this area, for example, of whatever the organ is, okay? And now, it's instead of 5,000, it's 50,000. And the 50,000 are competing on the blood supply that used to go to the 5,000, right? So they are going to compete, and part of the cells are going to die, but this is going to happen as well. Angiogenesis. Angio means, it's a prefix that means blood vessels. Genesis is a suffix that means generation. So what does that mean? It means that some cancers are going to make its own blood supply. Did you get this idea? Make its own blood supply. I'm not getting enough blood supply. I'm far away from the blood supply. What should I do now? I'm going to do angiogenesis. And angiogenesis is something that's important to know. Okay, angiogenesis. What's the angiogenesis? Tumors secrete some secretions to make its own blood supply. And if you forgot it, again, angio means vessels, genesis means generation. So they generate their own cells. So they make some new capillaries come to them. Okay? This slide is very important to know. The whole slide. Very important to know. What are the warning signs of cancer? What should you see? You have to know this and you have to memorize it. Very important to know. What are the warning signs of cancer? Number one, if you see any unusual bleeding or discharge, unusual. Not like you tell me that there is the period, for example. It's a blood that's coming. It's a discharge that's coming. But this is something usual, isn't it? But unusual is something else, right? Like, should you see blood coming with the stool, for example? Is that something usual? Of course not. Can you have bleeding from the vagina away from the period time? Of course not. You're not supposed to, right? So I'm saying unusual. This is something that you're not supposed to see. If you see that, of course it doesn't mean cancer. It's just a warning sign. It means find out what's wrong. It might be, maybe. So just a warning sign. Changing the bowel habits or bladder. Like, I'm having diarrhea. Oh, well, everybody get diarrhea, right? But it's been there for a couple of months. Is that normal? No. So this is something wrong. You have to think about it, what's happening. So the doctor will say, okay, let's do this, let's do that, let's do some stool analysis, maybe endoscopy, something like that. We have to find out why. It shouldn't stay that long. If you have diarrhea from the food, for example, it should stay for a couple of days, right? Maybe a week. But are you supposed to have a diarrhea for 2 months, for example? Of course not, right? So that will mean something wrong. I have discomfort in my bladder. I go to the bathroom. I empty my bladder. I still have this feeling here in the bladder. And it's going on. You have to think about it. Changing aorta removal. Any one of us, you can have any dark area in your skin, right? And this would be normal, isn't it? I mean, well, we can all have it. I have a patch here. It's a brown patch here. I have something here, maybe. That's fine. This is not a warning sign. It's a warning sign if color or size or shape changed. Meaning, I have this brown patch in my skin for the past 6 years. Anything changed? No, you're fine. But now, I notice that the color is changing. It used to be brown, now I see some yellowish and reddish. No, this is not something normal, right? You have to do something about it, and you have to find out why. It used to be about 1 inch or half an inch, now it's 1 inch. Is it increasing in size? This is not something normal. It used to be something like this, a circle, now it's becoming something like this, oval shaped or irregular shaped. These are warning signs for the skin tumors. So a mole or warts or something, that's benign, anybody can have it, that's okay. If it changed color or shape or size, this is a warning sign, okay? So that's why everybody, this is something for everybody. If you have anything on your skin, something that looks darker or raised a little bit or something, notice it. If nothing changing, you're fine, okay? This is something benign, it just maybe you don't like how it looks or something, that's fine, but it's benign. If you notice that something changes, why it's getting reddish, getting yellowish, discolored, there is something wrong. Yes, this is a warning sign, okay? Part of the skin that's a sore and does not heal. So let's say something like this. I have an ulcer in my mouth, and you can have that for a few days and go away. No, it's not going away. I notice it. Next week, still there. Next month, still there. This is a warning sign. Weight loss. You're losing weight. Are you eating good? Yes. Do you have any problems? Are you sick? No. Do you have any issues? No. But I'm weighing myself, and I used to be 200, now I'm 190, now I'm 180. I don't know why. If you don't have an explanation, this is a warning sign. Something like general signs, like anemia, or you always feel fatigued. Are you sleeping well? Yes. Are you eating well? Yes. Are you doing anything unusual? No. I don't have any issues, except that I have anemia, or I'm always fatigued. Fatigued means tired. I'm always tired. Do you sleep well? Yes. Is everything okay? Yes. This is a warning sign. If there is something like in the throat, persistent cough and hoarseness, anybody can get cough, right? Anybody can get cough, but how long should you get the cough? For a couple of days, for a week? That's fine, right? But are you supposed to have cough for 2 months, for example? Of course not. It's prolonged. So this is a warning sign. If you see a solid lump, like self-examination of the breast for females, and you notice something unusual, there is a lump there, okay? So this is not something good. Painless or painful? Which one is more warning? Painless is more warning. If it is painful, this is not warning. Most likely you have just a common issue. Maybe you have an inflammation or something. If it is painless, this is more warning. Okay? A lump that's painless, this is a warning. You have to find out what it is. If it is painful, it might be anything, inflammation or infection or anything like that. Breast or testes or something like that with the self-examination, and you see a solid lump, a solid mass, that's painless. Did you get this? This is very important to remember. Now, local signs and general signs of tumors. In this one, I want you to know the names. Just remember the names, okay? So, maybe some tumors will compress on something and make some pain, especially in the late stages. If it is beside a lumen or a duct or something, it can cause obstruction. It can cause necrosis or ulceration. And these are all local signs. So what are the local signs? Pain, obstruction, necrosis, and ulceration. Names are important here. These are the local signs. What do you mean by local signs? Meaning the tumor is causing something right beside it, locally. Okay, did we get this one? It's local, something happened local. Maybe it's pain, obstruction, tissue necrosis, or ulceration. All of those occur right beside the tumor. Okay? A tumor in the lung that's causing pain in the lung. It's local, right? A tumor in the liver that causes obstruction of the ducts in the liver. That's local. A tumor in the liver causing necrosis in the liver. That's local. Okay? But if this is something generalized, like weight loss where? This is generalized, systemic, right? So these are the systemic signs. Weight loss, I'm losing weight of what? Of the liver or this? We know it's the whole body. This is systemic. Cachexia, and I want you to know what's cachexia. Cachexia is severe tissue wasting. This is not losing weight. It's beyond that. Okay? When somebody say you look cachectic, means severe loss. Cachexia. Okay, so you need to know this. Other signs like anorexia, like anemia. Where is it? Is it local? Is anemia local? It's all over the body, right? This is systemic. Fatigue of what? Of the whole body. So ask yourself to know if this is local or systemic. Is it something happening right beside the tumor in the same organ or not? If it's happening something in the same organ, right beside the tumor, pain, obstruction, ulceration, necrosis, this is local. Anything that's happening all over the body, you call that systemic. And this is what I want you to know in this part. Okay? You can always read more, but you do not miss a word of what I'm saying. Okay? Cachexia, severe tissue wasting. So if you're losing weight, I don't call that cachexia. If you look, you know when they say like you look like skin on bone, right? Wasting, severe wasting. This is called cachexia. And this is something systemic because you're not losing the weight of the liver, you're not losing the weight of the stomach, you're losing your whole body weight. So anything that's happening in the whole body, I call that systemic. Okay? Something like infection, something like bleeding. Tumor markers is something that is systemic. And what's a tumor marker? Tumor marker is something that's used to be in the organ and now it appears in the blood. Okay? So, and there are some screening methods that can lead or just a little bit help with that. Something like this. PSA, for example. PSA is a prostate-specific antigen. This is a tumor marker. So, doctor, do you think I have a tumor in my prostate or something? Give me a blood sample. Blood in the whole body, right? It's not local. So give me a blood sample. I see PSA, which is prostate-specific antigen. So if that's the case, you might have a tumor in your prostate. How did I know? Finding the antigen in the blood. Which blood? Throughout the whole body. Isn't that systemic? So tumor markers is also systemic. There are a lot of tumor markers. Something like CEA, whatever. I mean, the names are not the most important, but just generally speaking, know that if you're talking about tumor markers are something that you find in the blood that can lead you or can tell you there is something wrong happening somewhere. There are some tumor markers for the ovaries, for the breast, for the colon, for the prostate, for the testes. There are some markers that they can get some blood and tell you that you might. Of course, it doesn't mean you have it. Tumor markers. Okay? So this is all important. And paraneoplastic syndrome, it's very important to know also. What's the paraneoplastic syndrome? Para means, it's a prefix, it means what? Do you know what's para? Para means around. Around. Para, and what's neoplasm means? Neo, what's neo? N-E-O? New. So neoplasm means tumor. Paraneoplastic means something happening around the tumor. Around the tumor, not the tumor itself. If that's the case, some tumors might release some secretions that are not supposed to be secreted. Example. Where do you secrete your thyroid hormone? From the thyroid gland, isn't it? Right? Where do you secrete the parathyroid hormone? From the parathyroid gland, isn't it? But this case, sometimes it happened that the lung cancer changed somehow and start to secrete parathyroid hormone. Why? It's a cancer, unpredictable. Are you supposed to secrete parathyroid hormone from the lung? Of course not. So if the lung cancer started to secrete parathyroid hormone, I call that paraneoplastic syndrome. Did you understand this? A tumor that's not supposed to secrete something, now it is secreting it. It's not your job. You're not supposed to secrete it. I call that paraneoplastic syndrome. This is just something, generally speaking, just read it. You can do screening, go to the doctor on a regular basis, find out if there is something wrong. Self-examination is specifically for the breast in females, for the testes in males, and skin for everybody. Just look at your skin in the mirror or something. Look if there is something that looks unusual or something like that. Blood test as needed. And here is a PSA I was talking about. PSA is a prostate-specific antigen. And this is the tumor marker that's one of the systemic signs. If needed, you can also do something like radiography, sonar, ultrasonography, MRI, CT, only if needed. If you are actually expecting something, you might. There is a good chance that you might have something. So let's do CT of the liver, for example, because you might have a tumor in the liver, or the testes, or the breast, or whatever. Any one of those can be done. And then the next step will be cytological test. Cytological, cyto means cells. So cytological means you examine the cells itself, meaning give me a sample of the cells and let me take a look at it, if it looks normal or not. And can you tell me now if you're following with me? Can you tell me what are the changes that if you see in the cells, you can say that this might be a cancer? This is on the tissue levels, yes, but on the cellular level. Should it be differentiated or not? If it is differentiated, it's benign. If it's undifferentiated, it's cancer. So undifferentiated, does it look typical or atypical? Atypical. Does it look normal? No. So what should you notice on the cellular level? What I just mentioned. Atypical, or poorly differentiated, does it look normal? Does not look normal. If you find those three on a cellular level, meaning you look under the microscope, look at the cells, and you see those, cancer. Give me a sample of your cells, and at least the cells are typical, looks okay, differentiated, and it looks normal. You tell yourself that this is a benign tumor. This is on a cellular level. I mentioned that this is important to remember. You have to remember it, okay? And I'm summarizing. I'm just giving you those. On the cellular level, differentiated, typical, normal. Differentiated, typical, normal. For benign. The opposite for malignant. Is that clear? On the tissue level, you mentioned it. If it is capsulated, it's benign. Does not invade or metastasize, it's benign. If it is not capsulated, it might be malignant. Invading, metastasize, malignant. Ulceration or necrosis, malignant. Did you understand this? So cytological level, you can understand exactly. And then invasion and metastasis, I mentioned that already. So invasion means you move from one spot to the adjacent spot. You're not moving to a far away organ, a distant organ. You're talking about something that's right beside the tumor. Okay? You have it in the breast, it's expanding in the breast. Expanding in the muscles right behind the breast. This is all called invasion or spread. Invasion. You're invading the surroundings. If it reach what? When it's going to become metastasis? What's the key word? If it reach what? The blood. Blood or lymph, exactly, yes. If it reach the blood or lymph, now the situation is different. Now you call it metastasis. So the cancer leave the original organ, let's say it was in the breast. Part of the cancer detach, reach the lymph or the blood, circulate in the lymph or the blood until it go to another spot, let's say the lung or the bone or something, and you call that metastasis. Did you understand the difference between invasion and metastasis? Both of them are leaving the original spot, but going where? Right beside it, you call it invasion. distant organ via lymph or blood, you call that metastasis. Here's an example of carcinoma of the cervix. So it starts like this. We call it the carcinoma in situ, and this is like the first step. And then it starts to invading the surrounding until it reaches the blood and go to another spot. Breast cancer, ovarian cancer, and so on. Now, if you're asked to stage the cancer, can you tell me the stage of my, somebody's having a cancer, can you tell me the stage of my cancer? Is it bad? Is it good? This will lead us to the TMN classification or TMN system that you need to know. You have to know this. T is for tumor. M is for metastasis. N is for lymph nodes. So this person goes to the doctor and he is having cancer. Can you tell me exactly what's the degree of my cancer? Okay, let me see. Number one, T means tumor size, the size of the tumor. If the size is small, then it's in the beginning. If it is getting larger, it's advanced. And then I am going to start to see the lymph nodes that's right beside it. If it reaches the lymph node, it's bad. If it doesn't reach the lymph nodes, it's not bad, right? And then you see metastasis. I'm going to scan all over your body. If you see metastasis somewhere else, like you're having cancer in the breast, and now I find it in the bone. This is of course bad, isn't it? So they always ask TMN. Tell me the classification. No, don't worry, you're fine. The tumor size is small, no lymph node, no metastasis. This is good, isn't it? This is good. Well, the tumor is a little bit large, and it will go to the lymph nodes. Do I have metastasis? No. This is bad, but not the worst. Your tumor is big, lymph nodes are invaded, and you have cancer in the bone or lung or something else. This is the worst. This is very poor. So according to that, you can say stage 1, stage 2. You don't need to know the details. I'm just giving you an idea. So they add those three together and they tell you your stage 1, 2, 3, 4, which is not something that you have to know, but you have to know the T and M classification. What's the T and what's the M and what's the N? TMN classification. Tumor size, metastasis, and lymph nodes. And this is something that's important to know. Now how the process of carcinogenesis occurs. Carcino means cancer. Genesis means generation. How do we generate the cancer? How the cancer is generated? There are different things that can change the control of the mitosis that we talked about. And if you lose the control somehow, or you lose something like the apoptosis. What's the apoptosis? Program cell death. If you lost your programmed cell death, which is apoptosis, or if you lost the control over the growth or over the mitosis, it can lead to cancer. Okay, but what's the very first sign that you will see and know that, which is the most important now, that it's becoming, it's on the way to become cancer. If you see irreversible change to the DNA, irreversible change to the DNA. If there is a reversible change to the DNA then, yes. Believe it or not, your DNA throughout your life, it can change a little bit, but your body will take care of it. The DNA is going to fix itself. Did you get the idea? We know the DNA, right? Do you know the DNA? The double strand, right? DNA. So the DNA will have a sequence like, do you remember the A, C, G, T? Do you remember that? So it should be arranged in a specific way. Sometimes it happens that something is replaced, or you lost the A is switched with the T. If that's reversible, your body or your DNA is going to fix itself, okay? And I call this reversible damage. If this is irreversible, meaning your DNA cannot fix itself, this is the first step, and when you see that, this is the first sign that you are on your way to develop cancer. So what is it? Irreversible change of the DNA. Irreversible change of the DNA. What can cause irreversible change of the DNA? A lot of things. A lot of things. Can be radiation, can cause that, right? When you go to the airport, for example, they scan you, right? This is something bad, by the way. If this is something that you have it once, twice, 3 times, that's okay. But if you are frequently traveling and going through this, this is bad. Every time it's this radiation go to your body, it's going to affect the DNA a little bit. Next time a little bit, next time a little bit, a little bit, a little bit, until it go to irreversible damage to the DNA, you will get a cancer. Okay? This is exactly like this. When we lose our teeth, kids, they don't lose their teeth all of a sudden, right? They just become looser and looser and looser, and then you fall down, right? This is exactly what's happening to our DNA. It's not like you pass through the machine one time and then you get the DNA bad. No, it doesn't happen like this. Just like your teeth. You're exposed to it once, 2 times, 10 times, 15 times, until irreversible damage to the DNA, that's it. It will lead to cancer. Environmental factors can lead to that. Radiation that I just mentioned. Infections, some infections. The very famous one, females. You have a vaccine for human papillomavirus, right? We all know that. Why? Why human papillomavirus specifically? There are a lot of viruses. Why this one specifically? Because this virus, what? Yes, because this one can lead to cervical cancer, meaning they found out that this virus specifically can cause irreversible damage to the DNA. So you can develop a cancer, right? And if that's the case, you call this oncovirus. Onco is a prefix that means cancer. Onco. Okay, so chemicals, can that cause irreversible damage to the DNA? Yes, if you are a worker working in one of these factories and you're continuously exposed to chemicals, it can. Radiation, if you're working in an area with a lot of radiation, or if you travel a lot, you are exposed, right? Viruses, some viruses, not all of them, few viruses can actually cause irreversible damage. How about overexposure to sun? What's the problem with that? Can you get skin cancer, right? Yes. So this is all something that can cause irreversible damage. So what's the first step? Irreversible damage to the DNA. And then if you're exposed to something more than that, it will ultimately develop and become cancer. And in order to go to cancer, you're going to lose the differentiation. Is that clear? I mentioned it so many times. Differentiation, typical, normal. Differentiated, typical, normal. These are the characteristics on the cellular level. What does the cells of the benign tumor looks like? Differentiated, typical, normal, right? You will start to lose that. The cells will start to look undifferentiated a little bit. You are one step moving toward the cancer, right? Start to look atypical. It doesn't look normal. Shape, size started to change. It doesn't look normal. It doesn't look typical. And then in this process, you can lose the apoptosis, and then you go to something like dysplasia, which is one step toward the cancer, dysplasia. So what are these risk factors? And this is important to know. Risk factors for cancer. Some genetic factors. Do we know that there are some cancers that if your parents have it, you have more chance to develop it? Not all cancers, by the way. Some cancers, right? And what did I mention about onco? Onco means what? Cancer. So oncogenes, the genes, bad genes, that can lead to cancer. You inherited the genes from your parents, from your grandparents, and this gene is an oncogene. The oncogene, the normal oncogene is protective. It's regulating. But if that oncogene is bad, you inherited a bad oncogene, you can have cancer. So what's the oncogene? This is the gene that generates the cell growth, okay? If something happened to it, it can lead to cancer. Normally, it regulates the growth, oncogenes. Regulate the growth, you don't get a cancer. If you have a bad gene of the oncogenes, you can develop cancer. Something like chronic irritation and inflammation. Something like smoking. Isn't smoking the continuous irritation of your lung? Right? And we know that can lead to irreversible damage to the DNA and can lead to cancer, right? Sun exposure. You're supposed to be exposed to the sun, but it should be only a limited time. You cannot be exposed to the sun 4 or 5 hours per day, right? You can't do that. Tanning, by the way, is doing a similar effect. So repeated sun exposure. What exactly in the sun? Which part? Do you know what's the bad part about the sun? The what? Yes, the ultraviolet. This is the one that actually goes down to your DNA, causes irreversible damage. Family incidents. Do you have somebody in your family that have cancer before? Yes, my grandparents, my grandfather, or my great-grandfather, mother died with this cancer or that cancer. This will mean that you have high risk. So everybody, when you go to the doctor, they should tell you if you are low risk or high risk of developing cancer. It doesn't mean you have a cancer, just high risk or low risk. So if you have the gene, you're high risk. If you have chronic irritation, are you a smoker? Are you a smoker? Yes, you are. You might. You are high risk. Do you work in one of these chemical factories? Do you work close to radiation or something? Yes, then you are exposed. Do you work in the sun? Like some workers, they have to work in the sun on a daily basis, right? Exposed to long exposure to sun. Family incidents. Oncoviruses, this is what I was talking about. Oncoviruses. Some viruses, not all, some viruses, if it happen on a continuous base, it can lead to irreversible damage to the DNA. And I just mentioned human papillomavirus, HPV, right? Ladies, females, you know HPV, right? So why HPV specifically? Again, it irritates the cervix and irritate the DNA enough, frequently enough, it can cause cancer. This is not the only one. There is another example which is like hepatitis C, for example. This is an oncovirus to liver. Like, we know that there are different types of hepatitis, right? Hepatitis A and B and C and D and so on. C specifically is an oncovirus because this is a virus, it's a viral infection, but it can cause continuous irritation. So oncovirus, and we need to know this, of course, this is important to know. When you see it underlined like this, it's important, okay? Radiation, if you're exposed to any type of radiation, you are high risk. If you're exposed to chemicals, if you're exposed to asbestos or heavy metals, basically if you work in one of these factories, you're exposed to cancer. Some biological factors like diet and hormones and age and all that stuff, this is biological. I mean, it's not really something bad or wrong happening, it doesn't have to be, but when you get older, do you have more chance to develop cancer? More than younger age? Yes. Why? Because the wear and tear of the DNA. You're aging and you're exposed to many more things, so you have more chances. Diet, if you're eating a non-healthy diet, like smoked food, for example, we know that this is bad. Smoked food, if you eat it on a regular basis, that's not something good. It's bad. So this is bad for diet. If you're not eating enough fibers, for example, this is bad for your colon, right? So you can't develop. All of these hormones, you have increased one of the hormones that's above normal. These are all called biological factors. So what should you do? Protect yourself against any one of these high-risk factors that we talked about. A good diet that contains fibers, self-examination, frequent examination, do not be exposed to sun for a long time, and so on. Immunity, cell-mediated immunity. Do you guys still remember the immunity, or you forgot it? Do you remember the cell-mediated immunity and antibody-mediated? Do you remember the immunity in general? If not, you don't have to say yes. I can explain just a limited part that's related to this. The immune system, your immune system is your body defense. Okay? Some of the immune system is non-specific, like your skin or something just protecting you. And some is specific. Specific is lymphocytes. Some of the lymphocytes are called the cell-mediated T lymphocytes, cell-mediated. What does it mean? These cells are going to go around in your body, and if they find the cancer, they're going to attack. Okay? They attack your own cancer. This is something that's under a lot of research. They are working on it and trying to develop it so that this cell-mediated immunity kill your own cancer. So now if you ask yourself, why people get cancer if you have cell-mediated T lymphocytes, for example? If these T lymphocytes are going to kill your cancer, why people still have cancer? Because they are not aggressive enough. They have limited ability to kill some part of the cancer. Let me tell you this too. Do you know that any one of us, and you don't have any problem, do you know that you might have developed cancer cells throughout your life and you don't know about it? You know that? You might, you never know. Maybe 5 years ago, you have a couple of cancer cells and T lymphocytes wipe it off. Eat it, get rid of it, and you're fine, right? So this is protecting. Treatment. Let me say this in treatment, generally speaking, in pathophysiology. Specific treatment is not the most important in pathophysiology. It's not the most important for your quizzes and exams. Okay? There are some exceptions. When you see me stressing on some treatment, this is the one that you need to know. If not, read it for yourself. But I'm not expecting much of the treatment. Pathophysiology is more of etiology and pathogenesis and so on. Not about the treatment much. It's not pharmacology. Okay? So except there are certain parts. So don't say, you said that the treatment is not important. I didn't say that. I said there are some parts of the treatment that you need to know. Just a little bit of this. A little bit, not details. Treatment can be surgery, cut the cancer, remove it. This is one. Or you can do chemotherapy, radiotherapy, or immunotherapy, and sometimes combinations. You combine. I'm going to do a surgery, and then you will get some radiotherapy or radiation for 2 years, for example. This is a combination, right? Or I give you radiotherapy and chemotherapy at the same time, for some reason. It depends, of course, it depends on different cancers, and this is not something that you need to know the details. Just know that it can be one or combination. Okay? Now here is something that's extremely important to remember. Extremely important to remember. Okay? What is too bad about chemotherapy and radiotherapy specifically? These two types, they kill any rapidly growing cells. It cannot, the cancer is rapidly growing cells, isn't it? Right? But how about your skin? Isn't that rapidly growing cells? Yes. How about your bone marrow? Do you know that you make blood not only on a daily basis? Every minute you make blood. So don't you know that your bone marrow is a rapidly growing cell? Your hair, your hair grow on a daily basis, isn't it? Right? So it's a fast growing cells. So any rapidly growing cells will be affected. We don't have the smart chemotherapy or radiotherapy that goes just to the cancer and target it. We don't have that, unfortunately. Until this moment, there is no smart chemo or radiotherapy. So if you have a treatment with the chemo or radiotherapy, it's going to be more of random. It doesn't go to the cancer only. It will go to the cancer and kill some of the cancer, but it will also affect every rapidly growing cells in your body. What are the rapidly growing cells that we have to know? Epithelial cells, like your skin, your mucous membrane, any epithelial cells. Epithelial cells, that's number one. Hair. That's number 2. Bone marrow, that's number 3. These are the most important 3. The most important 3 that are rapidly growing. So guess what? You need to expect that if you are taking radiotherapy or chemotherapy, your rapidly growing cells are going to be affected anyway. You have to know that, right? And we know that sometimes we see people having radiotherapy for leukemia, for example, and you see their hair falling, right? They become bald after some time. They become anemic. The bone marrow will be suppressed, right? They have some skin inflammation and so on. So always remember this. Chemotherapy and radiotherapy, especially if combined. This is even the worst, right? Chemotherapy alone will do it. Radiotherapy alone will do it. If you combine, this is even more, okay? So it's going to affect what? Rapidly growing cells. What are the rapidly growing cells that we have to remember? Epithelial cells, like skin and mucous membrane, right? Hair and bone marrow. If you think about it, which one of those is the worst? Is it the skin, the hair, or the bone marrow? The bone marrow. This is the worst. I mean, you lose your hair, you can regrow the hair. That's not that bad, right? The skin is affected, you have some inflammation, you're losing your skin a little bit, you will regrow. This is not the worst. The worst is bone marrow suppression. The bone marrow is producing all types of blood cells. What are the types of blood cells that we know? Red, white, and what's the third one? Platelets. Red blood cells, white blood cells, and platelets. Isn't this what the bone marrow do? If you suppress the bone marrow, you will have all of this reduced, suppressing the bone marrow. So you don't have enough white blood cells, you don't have enough red blood cells, and you don't have enough platelets. Okay? Here are some prefixes and suffixes that I want you to know. Erythro. Write it, memorize it. It's going to help you. Okay? Erythro, leuco, and thrombo. Okay? And then suffixes, pinia, and cytosis. Combine those and you will get a lot of scenarios. Okay? Very helpful. Just understand what does it mean. Erythro means red blood cells. Leuco means white blood cells. Thrombo means platelets. So this is red blood cells, this is white blood cells, and this is platelets. Okay? Now if you put pinia, beside it means decrease number. If you put cytosis, means increase number. Okay? So let me ask you, if you got this, let me ask you, what's erythropenia? Exactly. Red blood cells decrease. What's leukopenia? White blood cells decrease. Thrombocytopenia. Platelets decrease. How about leukocytosis? Did you get the idea? So, if I ask you what's happening here, can you tell me from this? You're suppressing the bone marrow. You get erythropenia, leukopenia, thrombocytopenia, right? All of them are penia. Did you understand my idea? The bone marrow is secreting the 3, the bone marrow is suppressed. You have lack of the 3, right? And what's the worst of all? Erythropenia, they call it more of anemia. Erythropenia, which is low red blood cells, they call it anemia. But here is the worst of all, those two. Leukopenia and thrombocytopenia is the worst of all. Okay, and you will see it here. Leukopenia, thrombocytopenia. This is the worst of all. Why? What's the general function of the white blood cells? Fight infection? Defense? Defense? Okay. And what's the most important function of the platelets? Generally speaking. Blood clot, so you don't have bleeding, right? Okay, so if you have leukopenia, you don't have enough white blood cells, you don't have enough defense. You get a lot of infections, right? And you can die from infections. If you have thrombocytopenia, you don't have enough platelets, so you don't have enough blood clot. You get minor injury and you lose all your blood. Is that clear? So this is the worst of all. Leukopenia, thrombocytopenia. Anemia is not, it's not commonly affected, not much affected, but this is the worst of all. Okay, did you understand this? Is that clear? Leukopenia and thrombocytopenia. This is the worst. Why leukopenia? You can get more what? Infections. Why thrombocytopenia? You can get bleeding, right? And you call this the rate limiting reactions or steps. Meaning, what's the rate limiting mean? Means I give you chemotherapy and radiotherapy, and let me see your white blood cells and platelets. You're still okay. Okay, continue. You come to me next month. You come next month. Your white blood cells and platelets are going down, but we're still okay. Continue. Next month you come. Stop. I can't give you the treatment because the platelets and the leukocytes are going down too much. I have to stop. So when should you stop? If those two are going down. This is called the rate limiting step. So a little bit of details. If you're talking about surgery, all what we need to know about this is just one simple thing. You remove the cancer with some healthy tissue around it. That's it. Not just the cancer. Because if you remove the cancer only, maybe some cells around it and you didn't see it. That's all what we need to know about this surgery. RFA is something that you need to know. Radio frequency ablation. This is simply you're using heat instead of cutting. That's it. Okay? So what's a radio frequency? Radio frequency is something, generation of heat through radio frequency. Ablation means you ablate something, meaning you remove it. So what's a radio frequency ablation? You're using the radio frequency to produce heat to cut. That's it. And instead of using surgical instruments to cut, you're using the heat. Okay? As an alternative to tumor, but this is usually in small single tumors. Did we get this? This is something important to remember. So radiation, I mentioned that already for radiation chemotherapy, right? What is the target for radiation and chemotherapy? Both of them, rapidly growing cells. You mean cancer cells? Not only cancer cells. Rapidly growing cells. Not just cancers. Your hair, your epithelial cells, and your bone marrow. And this is a problem. The radiotherapy, it can come from external source, like we're going to give you radiotherapy, okay, radiation. You get the machine, like the cobalt machine. There is a machine that's called the cobalt machine from outside, and they expose it to the cancer. But sometimes they insert something inside. And the example of that is, if this is a man who's having a small cancer in the testes, for example, you know what they do? They inject a radioactive material inside the testis, right beside the tumor, and it will locally kill it instead of doing a surgery. So it can be external or internal. If it is internal, they insert the material inside the tumor. And this is what we need to know here. And if you ask yourself, so what's the fate of that? You inserted one of these isotopes or the radiation into the testes or into the ovaries, for example, then what? It's going to decay itself. So it's going to lose itself after some time. After killing the tumor, it will be lost anyway. Okay? So bone marrow suppression, I talked about this. All three are going to be affected. Erythrocytopenia, which is anemia. Leukopenia, thrombocytopenia. And epithelial cells are going to be damaged, like skin, hair loss. One more thing that I didn't mention is your germ cells. Of course, we know that your sperms and eggs grow on a daily basis, right? This is one of the rapidly growing cells, isn't it? So if that's the case, it can lead to infertility. You don't produce the sperms or the ova anymore. So what are the rapidly growing cells that we need to know? Skin, or epithelial cells in general, epithelial cells, like skin and mucous membranes, that's number one. Hair cells, or hair, that's number two. Bone marrow, that's number three. And gonads. Gonads means ovaries or testes, okay? These are all rapidly growing cells that you can lose by exposure to radiation. Chemotherapy can be used alone or in combination with others. And there are different types. The details are not the most important. But this is the only thing that I want you to remember. Chemotherapy is some chemicals that kill the cancer, but how? Okay? They either interfere with protein synthesis or DNA replication. It's top one of those. This is what you need to know here. Okay? Details are not the most important. You can read it if you want to, but this is the bottom line here. Adverse effects of the chemotherapy. I mentioned it already. Any rapidly growing cells, right? Just the same as radiotherapy. But here, bone marrow depression is a rate limiting step. This is something that bone marrow depression is a rate limiting, and you need to stop the chemotherapy if that's the case. Limiting factor. Limiting factor means this is something that you have limits. You cannot just continue on and on and on. You can't give me chemotherapy unchecked and that's it. You can't. You have to check the blood. If the blood is still okay or a little bit less, that's fine. If you have leukopenia, what's the difference between neutropenia and leukopenia? Does anybody know? Just think about it. Yes, the only both of them are basically the same. Neutrophils is one of the leukocytes, one of the white blood cells. So leukopenia is depression or less white blood cells in general. Neutropenia is less neutrophils, which is one of the white blood cells. And this is the one that's affected the most of the white blood cells. And that's why they call it neutropenia. So whether you see neutropenia or leukopenia, it's penia anyway, and that's why I give you this, the suffix, so you can make up any other names. Can you make up these names? If you see it, can you know what it is? Just cut it into two pieces. Are we talking about penia or cytosis? And then the first part of the name. Okay? So what's the problem when you suppress your leukocytes or neutrophils? You'll be exposed to more infection. The other thing that's very frequent, like people taking chemotherapy, they always suffer from nausea and vomiting. What's the difference between nausea and vomiting? Exactly. Nausea is you feel like you're going to throw up. You feel like it, you don't. Vomiting is the actual throw up. So if you ask yourself, why is that happening? Because there are actually two reasons for that. The chemotherapy itself is irritant to your digestive tract, gastrointestinal tract. It's irritant. That's number one. Number two, it also stimulates the emetic center. What's the emetic center? What's emesis means? Emesis, emetic. Emesis is the same as vomiting. Okay? Emesis. And we have some centers in the brain, in the central nervous system, some centers like this. If you stimulate it, you're going to throw up. Even if there is nothing wrong with my digestive tract? Yes. Okay? Did you get this idea? Your digestive tract is perfect. You don't have any problem at all. Your stomach is perfect. Your intestine is perfect, but you're throwing up. Why? Because something in the brain. Do you know that if the pressure increased in the brain, you're going to vomit? In the brain, you're going to vomit. Why? My digestive system is fine, my stomach is perfect, my intestine is perfect. Yes, there is a center here in the hypothalamus, or in the brain stem. This center, if you stimulate it, if you push, if you press on it, or if you stimulate it by a chemical compound or something, you're going to throw up, even though you don't have any problem in your intestine. So it can be either or. Okay, so why we have nausea and vomiting with the chemotherapy? 2 reasons. One of them is actual irritation of your stomach, actual irritation of your stomach and intestine. The other one is stimulating the emetic center, which is a vomiting center. Okay, is that clear? Epithelial cells, hair will be lost, and skin problems and so on. Can lead to fibrosis or something like that. Other things that are important to know with so treatment here, I'm telling you about specifics about treatment that you have to know. So don't tell me that you said the treatment is not important. This is one of the exceptions. I will give you some exceptions. Okay? Glucocorticoid, for example. Why do they give glucocorticoid to somebody having cancer? Because glucocorticoid, which is cortisone, glucocorticoid, they decrease the inflammation. Okay? Decrease the inflammation around the tumor. So this will give us better results, glucocorticoids. Okay? The other thing is biological response modifiers. I just mentioned that cytotoxic cells. Did we just talk about this? Cytotoxic T cells. I mentioned that cytotoxic T cells, they kill your cancer cells, right? But they are not strong enough to wipe it off. It's not strong enough to kill it all. Now they are working on this, biological response modifiers, or the BRMs. BRMs is something also important to know. This is what I was just talking about. Augmenting your natural immune response. Stimulating the T cells to kill more. And this can be helpful. Unfortunately, this is not enough treatment by itself. They cannot count on it. But it's helpful. Okay? Now the other thing is, what's angiogenesis? That I mentioned like 10, 15 minutes ago. Angiogenesis. What's angio? Blood vessels. And what's genesis? Formation or generation, right? So if this is a cancer, and this cancer is secreting something to make its own blood supply, I call this angiogenesis, right? I call this angiogenesis. If I give you something to stop this, the cancer will die. Did you get my idea? And what do you call this? Anti-angiogenesis. Against the angiogenesis. Did you understand that or not? Some cancers secrete material, chemical compounds, to make its own blood supply. If you cut the blood supply, it's going to die, right? So this can be one of the treatments, okay, which is called anti-angiogenesis. Stopping the angiogenesis. So you're depriving the cancer from its own blood supply. You can give pain treatment or something that's adjuvant, but I told you about the most important of all. Nutrition, good nutrition is important. Some complementary therapies, that's good to know. I mean, it's not the most important, but yeah, you can do some massage, you can do some counseling, exercising, and so on. Now the prognosis. When you go to the doctor and tell him that, what are you expecting about my cancer? Is it going to heal? Is it going to cure or not? This is called the prognosis, which is 5 years survival without recurrence. Can I get that or not? If you can, it's good. So this is a good prognosis. Okay? The thing with cancers is, cancers goes exactly like this. Sometimes go like this and like this. Remission, exacerbation, remission, exacerbation. Okay? You need to know what remission and exacerbation means. Exacerbation means it gets worse. Remission means you improve. So you improve and get worse. Improve, you get worse. So you improve, and this is called remission. If you worsen, exacerbation. Remission, exacerbation. Remission and exacerbation. So what's remission? Remission means you're improving. Improving like what? You don't have clinical signs and symptoms. Okay? So you're having a cancer. How do you feel today? I feel bad, I have pain, and I have all of that. Okay, this is exacerbation. Okay? Come and see me in 2 weeks. You come in 2 weeks. How do you feel today? No, I feel okay. It doesn't mean the cancer is going somewhere or something. It's still there, right? But how do you feel? Do you have pain or something? No, I'm fine. Let me see. You look okay. Are you complaining of anything? Do you have diarrhea? Do you losing weight? Or do you feel pain? No, I'm fine. I feel fine. This is called remission. Okay? So remission doesn't mean that the cancer is going. Remission means you don't have signs or symptoms. You have complaints? No, I feel fine. You still have the cancer. Remission. Okay? And of course, part of the prognosis is the life expectancy. How long do you think I'm going to survive, or what's the life expectancy? 5 years, 2 years, 10 years, whatever. Now some special cancers that you need to know something about each one of those. Okay? And special cancers are important to know. Skin cancer, ovarian cancer, and brain tumors. Skin cancer. Skin cancer is very easy to diagnose. You can diagnose it yourself. No, and you don't even need a doctor. If you find something in your skin and you know what it is, and you know how it looks like, and later you see it changing, you can tell. Isn't that something easy to diagnose? You don't even have to do a lot of CT and ultrasound and all that stuff. It's very easy to diagnose. And usually the prognosis is excellent. The only one that's bad, generally speaking, benign and cancers of the skin are excellent prognosis. This is something that's not as bad as other cancers. The only exception for that, the worst one, is malignant melanoma. This is very bad. Okay? So anything else? Basal cell carcinoma, squamous cell carcinoma. This is all something that's good prognosis. You can actually get cured from it's cancer, but you can get cured. Except malignant melanoma. This is the only one that's really bad. Okay? What's the most frequent site for the skin cancer? The areas that are always exposed, like your neck and your head and neck. This is the most frequent site. The number of skin cancers is increasing in general because of the overexposure to sun and others. So the number is growing. And the basal cell carcinoma is the most common form of skin cancer. And even though basal cell carcinoma is cancer, but they treat it like benign tumors. Like, I will show you a picture. If this is a basal cell carcinoma, they do it in the outpatient clinic. You just cut, remove, and you're done. That's it. Okay? Even though it's called cancer. Is it cancer? Yes. It follows the criteria of cancer. It is a cancer. So you see the cells atypical, you see the cells that are not differentiated. Yes. Doesn't look normal. But even though it is a cancer, by definition, cytologically it's cancer, but it's a very common and a very good prognosis cancer. Just remove it. Basal cell carcinoma. So this is something that you need to know. Okay? Ovarian cancer, the only thing that I want you to know about ovarian cancer is people die from ovarian cancer not because it's aggressive, but because it's hiding and there is a big space around it. So it takes time until you realize that have ovarian cancer. So the prognosis is bad because of the hidden nature. You know, the ovaries are like here and there is a space around it. So here is ovarian cancer. You don't have no idea. Growing, you don't know. Growing, you don't know. Until it starts to become big enough that it's starting to bug you, start to bother you. And then you go, oh, that's too bad. You have that for a couple of years. You didn't come early. I didn't have a complaint, right? So this is why it's not aggressive, it's not, as a cancer, it's not bad by itself. It's just poor prognosis because you don't diagnose. Late diagnosis. Brain tumors. Can you die from benign tumors and malignant tumors of the brain? Yes. Malignant tumor, I understand that. But why benign tumor? Tissue compression. Tissue compression. You're going to compress the brain. Why people don't die from benign liver tumor, for example? Because around the liver there is a space, right? So if the tumor is pushing, the liver can expand. There is a space. Do you have a space in your skull? Of course not. It's confined, isn't it? So if the brain starts to grow and the same skull, the same room, you're going to compress the tissues. That's why people die from both benign and malignant. The other thing is, malignant tumor of the brain invade the surrounding but does not metastasize. What's the difference between invasion and metastasis? I mentioned it in the beginning. What's the difference?
Metastasis gets in the lymph or the blood.
Exactly. So can you get invasion in the brain cancers? Yes, it can invade the surrounding. It starts from the cerebellum and then it go to the cerebrum and it go to the brain stem. Yes, that's all local. It's invasion. Does it metastasize, like go from the brain to the bone, for example? Extremely rare, almost no. Why? Because people die fast enough that they don't even survive to the extent of sending metastasis in 5-10 years or something. So usually no metastasis. It does not spread. It's extremely rare because they don't even survive that long. Okay? So characteristics of the brain tumors, both of them are fatal. Both of them can lead to death. There is a local invasion, no metastasis. This is the basal cell carcinoma that I was talking about. Look, I added how it looks like this, rounded. Do you see in the middle, there is a depression here? This is the basal cell carcinoma, and they do exactly like this. They cut like this. They cut around, and that's it. You're fine. Here are different types of brain tumors. And this is something that this sequence is important to know. What's the most common cancer in men? Number 1 is prostate, followed by lung and colorectal. Here it's breast, followed by lung and colorectal. So 2 and 3 is the same. The only difference is number 1. Number 1 in men is prostate. Number 1 in women is breast. Okay? Is that clear enough? Okay. So that's it for this chapter.